Ami.
Hey, Rena. I'm so excited to be here and talk about all the great discussions and pearls gleaned from the recently concluded ACC.21 virtual. Maybe we could start, Rena, with you talking about the interesting topics from the pediatric congenital perspective.
Yes, thanks, Ami. What I found really interesting were the controversies in the ICU management, whether to administer colloid or crystalloid in post-op cardiac patients. It appears that protocols are based on regional or institutional practices and still not evidence-based, would you believe? And so within a physiologic range, fluid administration can vary without adverse consequences. Other interesting topics include when to use mechanical cardiac support in dilated cardiomyopathy, sedation and pain management after heart surgery, when to feed the hypoplast, and whether to send them home on digoxin during the interstage period. Most interesting was the latest in the treatment of MIS-C, multisystem inflammatory syndrome in children after COVID-19. How about in the world of adult congenital heart disease, Ami? What are the latest?
Well, we had some great controversial topics to discuss this year. So, one of our first controversies is really thinking about in pregnancies associated with adult congenital heart disease. How are we doing preconception stratification? And how do we really create personalized risk assessment that's multidisciplinary, prospective, and patient centered? So, we really concentrated on the fact that we can have EKGs, H&P, history and physical exam, and echoes in most patients, but in those who are WHO class 3 or those who have CARPRAG 2 or higher Zahara scores, and those who are physically inactive or with a poor functional status or desaturated, we needed to think of some of those higher risk lesion patients and think about what the additional testing looked like. We definitely confirmed that impaired peak VO2 on cardiopulmonary exercise testing, chronotropic incompetence, blood pressure or desaturation kind of decreases in exercise were associated with poor outcomes. We also discussed cross-sectional imaging in Fontanes and systemic RVs. We talked about severe AV valve regurgitation, and we addressed coronary abnormalities and aortopathies. So there's, a lot to think about. And interestingly, as we're doing better in the pediatric side of congenital heart disease, we continue to have new and different challenges on the adult side that we really need to address. Some of these can lead to poor outcomes, but generally only if we don't have a multidisciplinary team that is thought about conception, thought about delivery planning, followed the patient through pregnancy. When we're able to do that, we actually can do quite well. And so that was really exciting. We also had a great discussion of over 800 adult patients after a pair of coarctation in childhood and really tried to assess why is there some accelerated attrition later in life. It turned out that hypertension is present in 60% of these patients despite medications, and clinically we see that as well, with only 18% having good control of their blood pressure. If we then look at artery intervention or reoperation, we again see that really the degree of artery intervention is still occurring, and it's something we need to address in these older adults. And then a few risk factors for needing artery intervention or reoperation were LVOT obstruction and initial repair, less than a year of age at repair, initial transcatheter intervention rather than surgical, or if surgical, initial patch repair. Lastly, we did find that freedom from aortic valve and ascending aortic intervention was 53% and 81% respectively by age 70, risk factors being male gender and bicuspid aortic valve, which we'd seen before, really emphasizing that lifelong surveillance is important, not just into the younger years, but really into older age, because there are additional issues that will arise. Lastly, we did think about psychosocial issues and the fact that we have to recognize that there's a lot of health-related anxiety and a lot of depression that doesn't just affect young adults, but can even last into older adulthood. Lastly, we looked at the arterial switch. Although some of our operations have been around for a very long time, we do see that some of our newer operations, especially when it comes to older adults, like the arterial switch, do have an incidence of needing reoperation. For the DTGA patient, reoperation for the neo-aortic valve or the native pulmonary valve is low, and there's only really a minority exhibiting progression of aortic insufficiency. So the degree of AI at the time of neonatal discharge was one of the strongest correlates for late AI. And those with at least mild AI at the time of neonatal discharge had a threefold higher risk of developing at least moderate AI after 15 years. Important for us to recognize all of these issues. Lastly, we sometimes think of certain things as rather benign, and we really did find that late outcome of both repaired and unrepaired perimembranous VSDs was not entirely benign. In the Belgian registry of over 250 adults, the incidence of endocarditis, still persistent, was 2.3% in unrepaired patients. Subaortic stenosis occurred in 14% of repaired patients, and at least moderate AI was seen in 5%, with some patients requiring pacemaker placement. So, important for us to recognize that patients with VSDs even require follow up as they age. There were quite a few other interesting topics. Rena, I know there were a few more that piqued your interest.
Yes, Ami, very interesting. Actually, I found the session on heterotaxy particularly very thought provoking. I thought it was a very clever and catchy title. Whose side are you on? Well, heterotaxy is indeed variable and should be suspected in the presence of fetal bradycardia and complex CHD. There could be dextro or levocardia, midline liver, rightward stomach, complex congenital heart defects. And you know what? This could be recognized in utero now. BVH is very common, probably due to LV non-compaction, with interrupted inferior vena cava and possibly bilateral SVCs. Interestingly, spleen anatomy does not necessarily correlate with the atrial appendage anatomy, but generally a splenia is associated with right isomerism and polysplenia with the left. However, it is often a mixed picture, and it's best to focus on the overall constellation of findings: segmental anatomy, pulmonary and systemic venous abnormalities, AV and VA concordance, outflow obstruction, to name a few. In short, we must truly expect the unexpected when dealing with heterotaxy. Fetal counseling should depend on the security of the anatomic diagnosis and known outcomes. For example, the presence of heart block and hydrops with complex CHD is ominous, highly predictive of in utero demise. Dysplenia patients tend to do worse, especially those with obstructed TAPVR, functional single ventricles, and discontinuous PAs, because obviously their Fontan palliation is such high risk. Polysplenia patients have a higher possibility of BIV repairs and thus overall tend to do better. And as a group, kids with heterotaxy have about a 60 to 70% 10-year survival. Recurrence is pretty high as 10%, even without a known genetic cause, Ami. Also, there could be associated complications like ciliary respiratory dysfunction, and so many have post-op pulmonary complications as well, such as the increased need for prolonged vent support, ECMO, and even tracheostomies. About 40% have primary ciliary dyskinesia. I didn't know that before. Heart rhythm issues are also common because of the anatomy. Anatomy itself is responsible for the arrhythmias, but it could be both tachy and bradycardia, compounded by surgically induced arrhythmias. Surgical strategies are varied and should be uniquely tailored to the defect with both uni and biventricular approaches. BIV repair may be possible in 70% of left isomerism patients, but this could involve complex atrial and ventricular septation, reconstruction of systemic and pulmonary venous return, complex tunnelizations, and creation of extracardiac conduits, with, of course, AV valve reconstruction, repair, or replacement. Other non-cardiac issues can complicate heterotaxy as well: malrotation, biliary atresia, ciliary dysfunction, immunologic dysfunction, neurologic abnormalities. Interestingly, along the STS database over the past 12 years, there's increased operative mortality regardless of their stat category, with obstructed pulmonary veins, AV valve regurgitation, and other things worsening outcomes. Of course, BIV repair is preferred, but even single ventricles have reasonable 10 to 15-year survival rates. But it looks like uh, we can't cover all of these sessions in 5 minutes. This really is just a teaser, Ami, to pique our interest. So, anyway, check out ACC On Demand if you want to learn more. And remember, you can get both American Board of Internal Medicine and American Board of Pediatrics MOC credit.